Assalamu alaikum, everyone. I'm Arshman Jawad, fourth year student of Khyber Medical College. And the topic of my research is assessment of sleep quality and psychological distress of cancer patients undergoing chemotherapy in tertiary care hospitals of Peshawar, Pakistan, using PSQA and QSC scale, a case control study. So, according to UN data, cancer has been the leading cause of death in around 112 countries. Over time, there have been many advances in the treatment of cancer, like radio, surgeries, biologics, and most importantly, chemotherapy. Chemotherapy, despite its benefits, comes with side effects such as nausea, vomiting, which leads to poor sleep. Aside from this, I think we can all say that cancer patients experience significant psychological distress. Therefore, we wanted to collect data and analyze to see if these patients experience a significant amount of psychological distress or have poor sleep quality. Our aims and objectives are that we want to assess the sleep quality of cancer patients undergoing chemotherapy, to assess the psychological distress of cancer patients undergoing chemotherapy, and to find an association between the two. So moving on to methodology. Our study design is a case control study with a non-probability convenience sampling. Our cases included cancer patients undergoing chemotherapy at a tertiary care hospitals of Peshawar in an OPD setting, while our controls were age and gender matched patients with chronic illnesses like hypertension and diabetes who would come to the OPD setting, and they were not on chemotherapeutic drug like methotrexate. Since there was little to no relevant data in Pakistan, so we found a similar study in US and used that data to calculate our sample size using 95% confidence interval and 80% power in open-80. And our results came out 90 with 45 cases and 45 controls. But to increase the reliability of our data, we increased it to 200 with 100 cases and 100 controls. The data was analyzed in software SPSS version 22. Significance value of p-value significance of 0.05 was used. Chi-square test, binary logistic, and descriptive analysis were used. We used two pre-validated questionnaire, PSQI, which stands for Pittsburgh Sleep Quality Index, and QSC-R10, which is for questionnaire of distress on cancer patients. Our variables of interest included age, gender, type of cancer, occupation, and education. Now moving on to results. Of the 100 cases in control, about 47% were female, 47% were males, and 52% were females, with mean age of 41. The most frequently reported cancer was breast cancer, 24%, followed by GI and leukemia cancers, which were 23 and 21% respectively. And the least reported cancer was urological at 3%. Here we can see that about 75% of cases had reported poor sleep quality, which was determined by a PSQI score of greater than 5. A PSQI score of greater than 5 means poor sleep and less means good quality sleep. So 75% cases had poor sleep, 58% of controls had poor sleep. Similarly, 70% of cases had psychological distress with QSC R10 a cutoff score of 14, while only 49% of controls are distressed. Odds ratio for psychological distress and sleep quality was calculated, which came out 2.17 and 2.43 for sleep quality and psychological distress respectively, which signifies that there were more than twice the odds of cancer patients having disturbed sleep and psychological distress as compared to controls. Here we can see that sleep quality and psychological distress were moderately positively correlated in both the groups, with the R values being 0.65 and 0.38 in cases and control respectively. However, unlike other studies, our study did not find any significant association between type of cancer and psychological distress or sleep quality. Logistic regression was used to ascertain the effects of independent variables on sleep quality and psychological distress individually. Here we can see that among cases, age was a significant contributing factor. That is, with every increase in age in years, the odds of having good quality sleep increases by 19.2%. While in controls, government employees had a negative association. That is, the government employees had poorer sleep as compared to unemployed people. For psychological distress, among cases, patients who attained secondary education or higher were associated with having little distress. Similarly, in controls, self-employees had little distress as compared to unemployed individuals. So in conclusion, our study found that cancer patients undergoing chemotherapy had significantly higher levels of disturbed sleep and psychological distress as compared to non-cancer, non-chemotherapeutic patients, as well as age, occupation, education levels were some of the factors that affected them. Therefore, it is recommended that a multidisciplinary approach is adopted in the management of cancer patients, including oncologists, psychiatrists, and therapists, so that these factors are targeted as well, so that these patients have a better quality of life as they battle through this debilitating disease. That's it, and thank you.
Questions? I have one. Your case is p-value is 0.0.
0.05.
That was your reference, but your actual value came back 0.47. So that's not significant. Can you go back?
For
Okay. Assalamu alaikum everyone and good afternoon. My name is Kuratulan Shakur and today my talk is about reduction in average length of stay of emergency department in a cancer hospital using Six Sigma methodology. As we all know that prolonged length of stay in emergency department is a problem that is faced by almost every hospital around the globe. It is caused by multiple factors and it definitely affects the quality of care provided to the patient and the patient satisfaction rates. So this project focuses on simple and practical changes in day-to-day activities of emergency department, which helped us reduce the average length of stay by 30% without incurring any cost. We used Six Sigma methodology for this project following the guidelines from the NHS. So the Six Sigma methodology has 5 stages: define, measure, analyze, improve, and control. In the define phase, we identified the problem. In measure phase, we collected the baseline data. In analyze phase, multiple analysis tools were used, which helped us to identify the contributing factors towards the increased length of stay. In the improve phase, after brainstorming with these team, an action plan was devised and implemented. After reanalysis, we found that there were significant improvements. In the control phase, we used control chart to show the before and after results, and a control plan was created to ensure the continuity of implemented changes and sustainability. So we would go briefly through all the stages of this project. In the define phase, we used project charter, which was approved by the hospital leadership. Project charter has all the important information to initiate a project, such as problem statement, which you can see is increased length of stay. Moreover, there are details about team members, scope of the project, constraints, and timelines were defined to complete the project. In the define phase, we also conducted a patient satisfaction survey, and we found that the patients in the emergency department also demanded timely treatment in the emergency department. In the measure phase, we developed a process map, a detailed process map, which shows the patient flow starting from the patient identification and screening till the patient leaves the emergency department. So the process map actually helped us to identify what we need to collect as a data. Based on the process map in the previous chart, we developed a data collection plan which contained all the important data collection parameters. Since time constraints, we will be going through the first data element of the data collection plan, which is the monthly average length of stay in emergency department. So as you can see, the length of stay was increasing with the passage of time, passing the target of 180 minutes twice. One in the month of March 22 and other in May 22. Okay. After collecting all the data in the measure phase, we moved to the analyze phase. In the analyze phase, we used fishbone diagram as a first step, in which a brainstorming session was held with all the team members, and we identified all the possible factors that are contributing towards the increased length of stay. Since this list is huge, sorry. So we used Pareto analysis to track down the exact contributing factors. In the Pareto analysis, we took a sample of 128 patients whose length of stay was increasing, and their medical records were reviewed thoroughly. And we found that most of the delays were caused by delay in assessments by physicians and delay in diagnostic reports. Now, to find out why these two contributing factors were there, we conducted YY analysis. Delay by physicians was caused by multiple reasons, which included shortage of doctors, and the time for assessment was not defined for physicians. Regarding the delay in diagnostic reports, we found that there were a lot of communication barriers between the emergency department staff and the diagnostic services. Now that we knew what were the contributing factors and why they were there, we developed an action plan. Assessment time for physician was defined and made a part of the SOP. Adequate staffing level was ensured across the shifts. Better communication plan between the emergency department and diagnostic services was created and implemented, and periodic meetings were planned to discuss these action points. So in the control phase, we used this control chart. As you can see, it shows monthly average length of stay. The green dotted line separates the before and after data. As you can see, after interventions, the average length of stay has successfully went down. The mean average length of stay before interventions was 166 minutes, and after interventions, it was 140 minutes. We applied Mann-Whitney U-test to analyze this data and found that it was statistically significant with p-value less than 0.05. So we successfully implemented Six Sigma methodology, and it helped us reduce the average length of stay by 30%. In the next phase of this project, we will be including those patients waiting admission to the inpatient department and those who are being transferred from the emergency department. We used multiple references for this project. Only few of them are mentioned over here. These references helped us a lot in this project and with the literature review as well. So in Western countries, Six Sigma methodology has already been applied in emergency department with notable results. I would like to thank my team members for making this project a success.
Assalamu alaikum, everyone. I am Nadaziz. Today, the topic I'm going to present is F18, a better alternative of gallium-68 for radiolabeling of prostate-specific membrane antigen to detect prostate cancer. So it's a comparative analysis. Well, before the study, the hypothesis was F18 is better than gallium-68 PSMA. Well, as we know that F18 is a better radioisotope than gallium-68, so we did a match pair comparison whether it is a better conjugate for PSMA to image prostate cancer. Well, you all know that gallium-68 PSMA is a well-established radiopharmaceutical for prostate cancer imaging. Then why do we need to look for other radioisotopes? So let me tell you that there are few shortcomings that we see in the gallium-68 as a radio tracer. It has a very short half-life of 68 minutes. So we cannot do delayed imaging. It has a very fast excretion through kidneys, accumulating the radiopharmaceutical into the bladder, obfuscating the surrounding lesions, abdominopelvic lesions. Besides, gallium emits positrons with relatively higher energy range, affecting the image quality and providing a slightly poor spatial resolution. So all these characteristics collectively played a role in consideration of other radioisotope for the radiolabeling of PSMA. So what we did, because of the limitation that we could not do a head-to-head comparison with gallium-68 and F18 PSMA both done on a single patient, what we did, we chose 40 patients in each group. matching them on the basis of clinical parameters, including Gleason score, TNM stage, and PSA level. What we did, we chose patients like if we have a patient imaged after radical prostatectomy with the Gleason score 7 and T3 score, PSA level ranging between 180 to 200, then we will choose the same a patient with same clinical parameters in the other group. So what we found that in each group, F18 revealed around 111 lesions versus 105 lesions for gallium-68, and the sensitivity was calculated by SPSS, and it found out to be 92% and 90%. That was very significantly comparative. Our results were also concordant with the study conducted by Rocher et al., who detected a higher detection of F18 PSMA. When we further divided the results to see the detection efficiency of F18, we found that when we see the data for abdominopelvic lymph node, F18 is a better radiopharmaceutical here. But for bone metastasis, for supradiaphragmatic lymph nodes and local recurrence, both gallium-68 and F18 are good in detecting lesions. So our results were also concorded with the study done by Giselle et al., who reported a 94% sensitivity of F18 for the detection of pelvic lymph nodes, including lymph nodes that were as small as 1 mm diameter. So you can see that in image A done with gallium-68 PSMA and image B is done with F18 PSMA. Fortunately, we had a patient in our department having both scans with the gap of around 3 months. It was a patient for the follow-up of lutetium therapy. So you can easily see that due to the background activity, the surrounding lesions are camouflaged compared to the image B, that you can easily see the lesions surrounding the bladder. Besides, you all know that there are issues with bladder residual volume in prostate cancer patients. So even when we instruct patients to void immediately before the scan, there is some activity in the bladder that limit the detection for the consultants. So because of the time gap between the imaging of these two imaging, we cannot comment on the detection efficiency that which one is better and it has detected more lesions, because there were 3 months, and 3 months are so much for the development of disease. Disease can progress in 3 months. So you can see in image A, F18 PSMA, you can clearly see the prostatic activity compared to the image B done by the gallium-68. The activity is slightly blurred, the image quality is bad. So after the clinical superiority, we can say that gallium-68 PSMA and F18-68 PSMA both have significant value in the detection of prostate cancer lesions. But when we say when we compare F18 with gallium-68 as a radioisotope, we see that F18 has half-life of 110 minutes. It allows us to do delayed imaging and get a better target to background ratio. Besides, in terms of physical characteristics, F18 has a lower energy level of 0.65 MeV compared to gallium with 1.90 MeV, and higher positron yield of 97% versus 89.1. All these characteristics collectively provided a better spatial resolution and better image quality. Our results were also supported by a study published in European Journal done by Kim et al. It supports significantly higher spatial resolution of F18 over gallium-68. So you can see the image quality. The image A is very much better than image B. Here, it is a non-fused image. You can clearly see the background noise in image B done with gallium, and image A, which is done with F18, has a very sharp image. Target to background ratio is very clear, and these characteristics allow the consultant to create a better report. F18 also has some benefits in terms of cost, yield, and production methods. As you all know, that gallium-68 is a is a generator-produced radioisotope. Gallium, even though germanium has a half-life of 271 days, we can use the generator for 6 to 8 months. Still, the per illusion yield is around 11 to 17 MCI. So we can only do the scan of 3 to 4 patients at once. But with F18, we can produce a minimum of 2050 megabecquerel. That is very sufficient to image around 14 to 15 patients at once. You can see the graph that even though we can do 500 illusions with the gallium germanium generator, the per illusion yield is still 1/4 times lower than F18 per batch production. So the conclusion here is F18 can be a replacement, can be a better alternative for gallium-68 as a conjugate of prostate-specific membrane antigen. So these were the references. There was no study published in South Asia, very limited data, very limited literature in Europe because this is a newly established radioisotope and a radiopharmaceutical. So I would like to thank everyone for patiently listening. Thank you. Are there any questions?
Operative. So 18F is what we use already, isn't it? So what basically that's what we're doing anyway.
F18 PSMM.
So F18 is better.
With PSMM.
You have a question? Anyone else? Okay, well done.
No questions.
All right, next one. Mohammed Zareen.
यही है एक मिनट मैंने 2 प्रेजेंटेशन मेल की थी इसमें हम एक की चाहिए मुझे सिर्फ ये रिजल्ट्स का स्लाइड देखना है नहीं ये वाला नहीं है मैंने लास्ट में जो ईमेल किया डॉक्टर जरीन ये नहीं प्रोफेसर डॉक्टर मोहम्मद जरीन डॉक्टर जिया लिखा होगा
Yeah.
नेक्स्ट दो ईमेल डॉक्टर जिया ईमेल चेक
You have to go. Okay.
दोबारा सेंड कर फोन में
Sir, next.
That's okay. Sharif Bashir. Is Sharif Bashir or
Become,
Sharif
can you-
Bashir here?
Sharif. Sir,
He's
Sharif.
online. Okay.
Yeah. Unfortunately, I couldn't be there. Should I share my screen?
Sharif Bashir ko online.
Can you hear me?
Dr. Sharif, can you hear us?
Yes, I can. Can you hear me, sir?
We might not be ready for his time yet. Dr. Sharif, can you hear us?
Yes, I can hear you, sir. Can you hear me?
Yeah, and we are ready for you.
Okay, perfect. Can you see my screen as well?
We can see your screen, yeah, and your picture. There you go.
Okay, perfect, perfect. Assalamu alaikum, ladies and gentlemen. My name is Dr. Sharif Bashir. I am fellow cytopathology at Shaukat Khanum Memorial Cancer Hospital, Lahore. First of all, I would like to thank my symposium organizers as well as the abstract review committee for this experience and for this honor. The topic for today's discussion is EUSFNA in pediatric population. This is a very nice study that we are currently in process of publishing, coming here from Shaukat Khanum, Lahore. This is our experience that we are going to share. So the authors declare no conflict of interest. So this is going to be our agenda for today. We are going to have an introduction to EUSFNA along with its advantages and material methods of our study and the results, and then the discussion. What exactly is EUSFNA? EUSFNA was introduced back as an EUS, and also it could actually visualize the lesions around intestinal tract, going through by an endoscopic approach and using using the real-time imaging of ultrasonography. But its value was really limited because yes, you could see the things around and the lesions around the gastrointestinal tract, whether it be lymph nodes or it be any lesion the pancreas. But in 1991, it was combined with FNAC, that is the final elaceration cytology.
Can you stop for a second? If you turn off your video, we'd be able to hear you better. We're having trouble with the audio. Yeah, go for it.
Okay. So in 1991, when it was combined with EUSFNA, then its utility was great, because now you could not only visualize those particular lesions, but also you could sample those lesions in order to diagnose and stage different kinds of tumors as well. So EUSFNA is done by primarily a gastroenterologist with on-site adequacy by a pathologist. And moreover, you can have the cell block and culture material collected for further investigations. So this is really the timeline, the gist of what happens when a patient with a GI lesion, whether it be an abdominal mass or is there any mass in the pancreas causing obstructive jaundice, presents in an OPD setting. So the patient presents to the gastroenterologist, and then naturally radiology is done to look for the lesion. Where is the lesion? What is the nature of the lesion? The CT abdomen pelvis helps us in identification of that lesion. And then the EUSFNA comes in. EUSFNA is done by the GI team with rapid on-site evaluation done by a pathologist then and there to perform the adequacy. And then for further investigations, the DIF-Quick stain, the PAP stain, and the cell block material is analyzed for further diagnosis. And yes, in some cases when you do not have a very clear diagnosis, or you want a definitive diagnosis, or you want to grade the tumors, like in neuroendocrine tumors, you can utilize the immunohistochemical stains on the cell block material. And as a result of that EUSFNA staging, as well as the cytopathology report, as a result of it, the management plan is devised. So this is the essential timeline of this particular procedure. Why are we talking so much about EUSFNA? Why you can't go for an open biopsy or a CT-guided biopsy? I mean, the advantages for EUSFNA are definitely far more than other modalities, especially when you are dealing with lesions in gastrointestinal tract and around it. It is a minimally invasive procedure. It can, yes, you can avoid ERCP as well, which is relatively more invasive. And not only US is a diagnostic procedure, it can be therapeutic, and it can be combined with other procedures to perform stunting or other things. And there is no extensive preparation that is required for EUSFNA, and it is a daycare procedure. And it can also provide you access to difficult sites which are inaccessible for radiology for CT-guided biopsies. And definitely it's faster, relatively cost-effective when compared to an open biopsy. And definitely on-site adequacy is something that helps us increase the yield of specimen. And again, there is relatively less morbidity associated with it, and reduced chance of needle tract seeding. So the advantages of EUSFNA are great. And it is well known as in adult patient to perform an EUSFNA, but in pediatric population, it's relatively not that common, you can say. But in the last decade, people are doing it more often because you have to have a smaller equipment size, as well as you need patients to have the tolerance for this particular procedure. They say that you need to have a 15 kgs above body weight, And if you have that, and if the patient is relatively tolerable to tolerance is good of the patient for this particular procedure, so it is now becoming very common in tertiary care centers around the world. But the studies are relatively limited for USFNA in pediatric population, and that is why we thought of coming up with our experience. So what did we do? We analyzed the data of last 17 years from 2005 to 2022. The inclusion criteria was simple. You need to be under 18 years of age, in-house patient, because in in-house patient, we have the liberty of complete demographic, clinical, and radiological record, and a successfully completed EUSFNA procedure, because sometimes you need to, for whatever reason, you need to stop the procedure. So these were the inclusion criteria. And what were our key points of focus in this particular study? That we wanted to analyze the demographic details, the indication of procedure, the rapid on-site adequacy status, and the site of lesion, and obviously the cytological diagnosis. And as a result, the adequacy was 86%. As you can see that out of 64 patients, which was our total population, 55 had an adequate sample, with total number of average number of passes, were 2.17, which is quite good actually. Most of the patients were male with a mean age of 12.4 years. The main indication was in large lymph nodes, because in pediatric populations, Hodgkin's lymphoma and lymphoproliferative disorders are somewhat more common. And as a result, when you have an enlarged lymph nodes, a para-aortic lymph node, or some carinal lymph node, you need to sample that. And that is why our indication in most of the cases was enlarged lymph nodes. Other included pancreatic mass and paraesophageal mass as well. And as I told you, the subcarinal lymph node, or the lymph nodes, were the most common site, and they were followed by pancreas and celiac axis lymph nodes. The diagnosis, the most common diagnosis was involvement of Hodgkin's lymphoma. As I told you, young population, lymphoproliferative disorders, Hodgkin lymphoma, more common. And in most of the cases, 26.6 cases were actually positive for Hodgkin's lymphoma. And it was followed by granulomatous inflammation in the lymph nodes or reactive lymph nodes as well. And there were some also peculiar findings that I will tell in the next slide. Ancillary studies, the cell block material was made in 70% of the patients, and immunohistochemical stains were performed only in 21.9% of the population, because the rest of the diagnoses were clear-cut and did not require immunohistochemical stains. The sensitivity of this procedure and this study was 76.5%, as definite diagnosis was rendered in those particular cases, and specificity of the diagnosis was quite good, actually 96.3. And the peculiar findings that I was telling you about earlier on, we found 3 cases of solid pseudopapillary tumor. Yes, it is relatively uncommon tumor, and we found 3 cases in USFNA. 2 cases were of recurrence by Wilms tumor, and 1 case of metastatic rhabdomyosarcoma and neuroendocrine tumor. So this is a case of Hodgkin's lymphoma for my pathology friends. You can see in the upper left corner, you have those RS cells with prominent nucleoli. There's this cell block, and then you have the CD30 stain with Golgi staining and PAX5 weak staining. So this is just to show you how it comes out on the slide, and immunohistochemical stain. Very nice example of solid pseudopapillary neoplasm. You can see this, the left side has this Diffwick stain of cells which have some fibrovascular spores running around them. The cells are not very atypical, but yes, they have some atypia. And on right side, you can see the beta-catenin stain, and the CD99 not very well visualized over here, but it was nicely dot-like positivity, which is characteristic of solid pseudopapillary neoplasm. So this is just a journal overview that I can provide you with. And we use these 2 studies. The Barbara is the global review, and the Zahir et al. Was the largest Indian review. You can see the study population was quite similar in both our experience and the largest Indian study. The Barbara global review was actually a combination of multiple articles that have been written. So that is why the population is quite large. The adequacy status, we were quite similar to the largest Indian series, that is Zahir, 86% for SKM and 88.3 for Indian study. For global review, they had a little better adequacy rate. The main indication, as I told you, in our study was in enlarged lymph nodes, but in the other studies were pancreatic lesions. Mean age was relatively same. Most common site in our study was subcranial lymph nodes, but the other studies had pancreas as the most, and the pancreatic lesions as the most common site. The sensitivity compared to the other study was a little low in our study, but still very decent sensitivity rate, and specificity was relatively the same as far as the other experiences of the other people. So these are the two reference articles that I was just mentioning that we used in our study and that provided the basis for references in our study. So concluding this all up, EUS is a minimally invasive and a very cost-effective procedure, and it provides access to the radiologically inaccessible sites, and rapid on-site evaluation provides a greater yield and a quicker diagnosis. I thank you, and if you have any questions.
So we just wanted to know,
Sorry, is there any question?
so yeah, no, majority of the time they're sedated, but even basic complications,
Can't hear you clearly. If there are any questions, please. Thank you.
for you guys. Very nice. It's very good that you give us a the procedure and we get the diagnosis that it's the treatment options are perfectly fine.
Can't hear you, sorry. Are there any questions? The voice is not clear here.
Today I'm here to discuss my research on laboratory for the focus measure for pancreatic tumors, comparison of file. So let's start with brief background of my research. As you know, pancreatic cancer is fourth most common cause of clinical death. Despite improvement in medical care, chemotherapy, radiotherapy, and molecular biology, pancreatic cancer has 75-year survival rate of 20%. Pancreatic clinically a mainstay treatment for benign and resectable treatment. There is tumor of pancreatic pancreatic cancer. It is performed through open subsequent or laparoscopic. Laparoscopic pancreatic urinectomy is associated with shorter hospital stay and short-term mortality. This is reporting the issue of LPD or OPD in developing countries. Our research came to analyze and compare the efficacy of LPD and OPD in Pakistan. So this led to objective of one study. If we were to compare the outcomes of patients undergoing laparoscopic pancreatitis with those undergoing open pancreatic surgery. This was basically a case-based comparative study conducted at the Department of Surgery Capability Hospital, Peshawar. A random sampling of 24 patients was selected, and the target population was patients with diagnosis of resectable peri-insulin cancer, carcinoma, and duodenal involuntary pancreatic care. Of age 30 to 70, irrespective of age, the diagnosis of resectable peri-insulin and distal carcinoma were eligible for surgery. And those patients with age and 4 and patients with specific disease were excluded. Data was collected from patients who sent with this question for demographic finalization data was obtained from the American record. 12 patients with open pancreatic disease and 12 patients with laparoscopic pancreatic disease were included in this study. And data analysis was done using SPSS person time. So now this slide shows the comparison of definite variable of both the groups. Here you can see the age. The majority of all of these areas are quite comparable to two groups. Here you can see the age group for LPD was 31.2 years and patients with open pancreatic disease was 3.4 years. For actually, the male 5 patients in the LPD group were male and 3 patients in the OPD were male. Similarly, BMI for pathology and comorbidity were fairly ranged between these two groups for accurate comparison. This slide shows the outcome variables and comparison between OPD setting. First, length of hospital stay. The length of hospital stay was 9.25 days for laparoscopic pancreatitis versus 18.25 days for open pancreatic disease, which was significantly lower from open pancreatic disease with p-value of less than 0.01. Similarly, operative time of 491 minutes for laparoscopic pancreatic disease and 282 minutes for open pancreatic disease. And operative blood loss for 245 ml for laparoscopic pancreatic disease and 437 ml for open pancreatic disease. The frequency of delayed gastric was 1 in laparoscopic pancreatic disease and 4 in open pancreatic disease. But this was not statistically significant. Similarly, readmission rate 3 for laparoscopic pancreatic disease and 2 for open pancreatic disease. 2 patients among the left pancreatic disease underwent re-intervention, while 1 patient in the open pancreatic disease group underwent re-intervention. The mortality rate for laparoscopic pancreatic disease was 1, and for open pancreatic disease was 3. Again, there is no significant difference in the mortality rate between the two periods. So in short, the length of hospital stay, operative time, and intra-operative blood loss was significantly different between the two procedures. Length of hospital stay was significantly shorter for laparoscopic pancreatic disease, and intra-operative time was significantly longer for laparoscopic pancreatic disease. This graph shows the significance between the rate of hospital stay between open pancreatic disease and laparoscopic pancreatic. In conclusion, despite the shorter operating time of open pancreatic disease, the overall benefits of laparoscopic pancreatic disease may get approach for eligible patients. However, careful patient selection and surgeon expertise are crucial. Thank you so much. If you will have any questions or suggestions, you can ask.
I do. It's a very, very, very fascinating for study. They don't need the both computer done. Both of them were performed in same sensors and purpose document with the secondly question about length of stay. Length of stay about how to get into like a lunar media and or in terms of this so analysis. Is it median or mean? This was the mean value of generally the median which is important helps to get a better idea about that. Everything applies to time operating time. Only one line. Thank you. Well, majority of cases, the lower BMI, the lower patients whose BMI are lower. So we can select open group, either compare with BMI and down. It was human care London, but due to certain limitations, we did not include. Yes, that's right. Open mental. Mindful. We have a few government setup and the payments of something that I can fix and very high. So you don't get the issue on both of this side and they use resource limitation. Yes. Thank you so much, sir. Yes, sir. Yes. Very much of it was that we are working as a medical officer, party of the quality and award. The topic of my presentation is clinical outcomes and long-term effects of palliative radiotherapy in pediatric hospital population. That is study that we did in our institute in the retrospective cohort study. So a little bit about introduction. Pediatric hospital comprises of 6% of all the child cancer. And over the decade, there has been significant improvements in the chemotherapy treatment related therapies. There has been significant improvement in chemotherapy outcomes and treatment modalities, with 5-year overall survival of hospital lymphoma being more than 80%. The qualitative radiotherapy is an important component of treatment in patients who have dealt with retinal respiratory disease when the patient is performed at the medical system. However, the radiotherapy exposes the patient to various side effects, secondary medications, various long-term side effects are also included cardiovascular disease, left ventricular dysfunction, and infertility in long-term neurotoxicity and pulmonary fibrosis can also occur in later life, as disease in the various cancer. So the aim of our study was to explore the long-term disease outcomes and gain effects of consolidative radiotherapy in possible. So the rest of our knowledge, no data has been published from world middle-income countries. It is looks at radiotherapy outcomes and it gains effects in such water patients. So our study design is a retrospective cohort study done at Hospital between from January 2017 and December 2019. We took a total of 91 patients. The including criteria was that patients were diagnosed with pediatric hospital lymphoma between ages of 1 to 18 years and with a follow-up of 5 years treatment. All patients were qualitative radiotherapy, but we were included in this study. So when we performed the PET scan, admitted assessment and labeled presence of residual disease without complete metabolic remission, these were the patients who were getting included in our study. The disease treatment and allocation was done according to the Euronet pediatric hospital lymphoma guidelines, which is the largest trial in the European done in the various institutes of Europe. And patients of the patients were of that ABD 4 to 8 factors of that and ABD chemotherapy. So, which population was excluded? These included patients who achieved complete metabolic remission of indirect PET scan and did not require consolidated radiotherapy. What are the rules of radiotherapy that was given? All patients with presence of residual disease on indirect PET scan received radiation doses of 19.8 days. Standard dose and was given as pillar infection with a dose and was given to patients with bulky disease videos of 10 days and 5 years. And the risk stratification of the patients were based on the Euronet guidelines, and the patients were risk stratified into low, intermediate, and high risk group based upon the disease state and the nature of the bulky disease. So that the patient is 1A, 1B, and patients with 2A stage without bulky disease and ESR rating were specified as low risk. The patients with stage 1EA, stage 1EB, and stage 2EA and 2B, and stage 3 that is stage involvement were specified as intermediate risk, and patients with stage 2EB, CEAB, and stage 3DS and stage 4A and stage 4D were included as high risk. So patients were then followed up for a maximum of 5 years. And disease status was evaluated at that time. And data sets included and targeted ultrasound therapy. Targeted ultrasound and echocardiogram, and echocardiogram and pulmonary function testing in period and thyroid profile. Disease progression, relapse, death, and loss to follow-up was evaluated when it was considered as events. So these are the variations which included, most of our study population were males, they were around 80%, and a higher population was of stage 4 disease, which shows that most of the patients these are diagnosed at a very later stage when they come to us. And a majority, almost 90% of the patients were certified in high risk group. These symptoms were present in 38% of the patients. So let's talk about the outcome. So what was the disease stage after the chemotherapy and chemotherapy? So 65 patients out of 71, that is 72% patients had complete metabolic response. That is complete eradication of the lymphoma. Stable disease is found to be in 17 patients, and disease progression was unfortunately found in 9 patients, that is almost 10% of the patients. As far as the outcomes are concerned, 76.9% complete remission, 4.4% received in progression. 6 patients ultimately come to the disease, and lots of follow-up from the so the overall survival of in our study was extremely good, around 90% of the overall population. And if we stratify according to the stratification, we see that low risk intermediate risk patients had almost 100% survival at 5 years, but the high risk patients had a survival rate of 85.3%. Similarly, if we see event-free survival here, so when we include the abandonment or loss of follow-up as an event, the event-free survival that comes down to 76.2%. And if we see, and if we certify according to the basic on this certification, we see that low risk intermediate risk patients had a better event-free survival. However, the highest patients had poor survival. Poor as compared to the lowest patient. So the 5-year overall survival rate in our study is 90%. This is in line with the data internationally. If we compare it with the studies from the studies in South Asia, in the Middle East, and in India, the survival rate is almost 85 to 85%, which is in line with our study, the overall survival. Similar survival rates are also reported in the lower middle income countries. Our study is really the biggest treatment-related complications were included hypothyroidism, and pulmonary fibrosis. In fact, ataxia was a rare complication found in only 1 patient. So international trials are ongoing for omission of radiotherapy in certain cases to reduce the rate without compromising the outcomes. The studies from India recommend that radiotherapy can be safely omitted even with bulky disease and chemotherapy regimens like OPTAC and OECA that can give favorable outcomes for the patient. Advanced radiotherapy techniques like intensity modulated radiation therapy and proton therapy can minimize long-term outcomes. And one more thing that I would like to discuss is their patients should receive that we need for the cost-effective cohort study, which can that we need for the cost-effective cohort studies in which we deliver radiotherapy to the patient at the end of treatment rather than academic estimate assessment. So if we have residual disease academic assessment, we should continue the chemotherapy and perform the PET scan. We perform the PET scan at the end of the chemotherapy session. And if there is residual disease, then we can go for low-dose chemotherapy. We need more cost-effective cohort trials over that. So let's include other analysis more favorable 5-year overall inventory survival in genetic hospital lymphoma, cost-effective trial and need to explore potential advantages in reducing chemotherapy doses, the rate of PET scan imaging findings. And this approach will help us minimize treatment-related complications while ensuring treatment effectiveness. So these are the references. Thank you. usual cases would be that the patient some cases had disease progressing, and a few cases of about 5 to 6 had disease had relapsed and like ultimately there was management of the patient. Most probably the interest was to follow up. These were also cases of that who didn't came back for the. Then if you see in percentage, it was 5 to 6% of the cases.
थोड़ा सा आगे आ जाइए।
So when the patients were at end of treatment and they had negative fertility, we call the patients that for follow-up for after 3 months. And if the patients have abdominal disease, we perform ultrasound and test. So we do not aggressively we do not aggressively investigate for the consultation because of the recent guidelines from the Children's Oncology Society. We want to recommend doing a bi-yearly or yearly practice or activity care. And instead, we recommend that if there is a clinical suspicion or a palpable lymph node, the resistance and if the resistance has any suspicion, we can get a biopsy done. And we need to follow the patient with regular testing again, the test exit, and target from the data. We need to do that.
Teacher है इस पर। वो माना वो कितने
Then really from the direction we want. Sometimes it is closer to the for biology, a fundamental component for physical state, which means the mechanism and coding regulation for the form of the body. This is the question of positive sentinel responses, do not create any positive non-sentinel. Recent proposal has focused more on finding evidence to minimize auxiliary lymph effects as much as possible to eliminate substantial side effects and morbidity associated with it. This emphasizes the need to evaluate other things of positive factors. It could better predict more sentinel lymph involvement and avoid unnecessary auxiliary lymph effects in a select group of patients. With this background in our mind, the objective of our study is to find the correlation of histopathological features of primary breast cancer positive sentinel and non-sentinel after auxiliary lymphodepletion to identify factors that may help in predicting involvement of non-sentinel. To study the effects of number association, size of metastatic and extramedullary extension of positive auxiliary sentinel biopsy in predicting positivity of non-sentinel. 130 breast cancer cases with positive sentinel those who underwent auxiliary lymphodepletion were selected for the study. Two senior pathologists reviewed the results of the cases. Univariate and multivariate analysis are performed to assess the relationship of the logical system with status of non-container electron involvement by applying logistic detailed science. Distribution of physical inequality and determination for the size of the largest metastatic focus was defined as the largest dimension of the largest correlated metastatic tumor focus is centimeter dimension. Area covered by metastatic tumor was defined as the area over which all the metastatic tumor foci are spread during the night and its adjacent extramodular location of the metastatic tumor foci was recorded as subcapsular intraparenchymal or both. Patients who receive neoadjuvant treatment, presence of micrometastasis in the sentinel lymph node and the presence of isolated tumor cells were excluded from the study. The mean patient age was 54.9 years. The mean tumor size was 3.3 centimeters. The predominant tumor type was major carcinoma and most type in 87% of it. Predominant stage was grade 2. This was in 63.8% of it. Predominant clinical stage was T2 in 70% of cases. Lymphoedema invasion was seen in 72.3% of cases. The molecular subtype of predominant type was luminally seen in 4.6% of cases. Total number of sentinel lymph node in this case ranged from 1 to 11 with a median of 3. Number of positive sentinel lymph nodes in this case ranged from 1 to 8 with a median of 1. Size of the largest metastatic focus was 7.4 mm. Area of the largest metastatic focus was 52.9 mm. Number of metastatic foci in the largest positive sentinel lymph node ranged from 1 to 10 with a median of 1. Location of metastatic foci in the largest positive sentinel lymph node was subcapsular only in 23.5% of cases, intraparenchymal only in 18.3% cases, and both 58.2%.
ये जो कह रहे हैं ना 4 फीट का तो इसकी टेबल भी नहीं होता, वो टेबल की जो आता है वो 2.5 फीट का आता है। और दूसरी चीज ये है कि टेबल नीचे लगाते हैं, टेबल नीचे लगाते हैं तो उसका साइज और एक्शन साइज सेम नहीं होगा, या वो टेबल इसमें छोटा होगा या वो टेबल नीचे दोनों साइड से बाहर निकलता होगा। उधर कुछ साइड से जो ब्रांडिंग लगाएंगे वो इनको दिखाएंगे, ठीक है ना, क्योंकि ग्रेड का हमारा डिस्कशन ही यही हमारी फ्लोर लेवल पे ही डिस्कशन हुई, तो उसमें ये देख लीजिए।
And actually, for the value of 0.04. Multivariate analysis was performed only for these three variables, so the value of 0.0 area of the current and static solution. High square test was possible with variables were also performed with different control values and show up in value of 0.021 for area of the current metastatic focus. Our study demonstrated a non-sentinel positivity rate of 26.9% with a median of 2 positive non-sentinel in non-sentinel positivity. However, 63.1% patients with positive sentinel biopsy did not have further positive sentinel. Area of tumor deposit was the only predictor of non-sentinel cases with significant reduction for univariate multivariate scan. Other international studies also show similar results of our study in relation to negative sentinel lymph node biopsy rate. So, replication of the study is that on a single center, they close practice study in a relatively smaller sample size. Total practice analysis limitation, such as sampling intent, time limitation, interpretation variability, and limited samples to express information rate can hinder the of negative of effect And extended exercise for needed only negative law and no, which points to the fact that the drug national value of human is not evident enough to predict no sentinel is very important. In basis the need to evaluate other responsible any of the largest metastatic tumor focus found to be the only factor relating no sentinel or possibility on multivariate manner. Further studies are required on larger cohort to validate these analysis findings. Thank you.
ऑनलाइन तो है लेकिन शायद उनका ऑडियो पे
I'm there. I'm there. Can you hear me?
I know you would need to cut off in dividend or my name is Muhammad Khan. The third student at University College Tower, and research student at Rahman Medical Institute Tower. The topic of my abstract is classifying non-risk activity and non-suspicious activity in glioblastoma into subgroups and risk categories on the basis of a minimal methylation basis. Glioblastoma is a malignant brain tumor that originates in seven. It is mostly a pediatric tumor. All medulloblastomas are WHO grade 4. Although two medulloblastomas might look the same on histology and radiology, the patients might have different outcomes. Throughout the years, we have found that it is due to the different molecular biology of the disease. Now, there are 4 concentric groups, not in the brain, as we said, for the molecular pathways, and then group 3 and 4. Group 3 and group 4 are also called as non-infectious medulloblastomas. Now, this classification of medulloblastoma has evolved over the past decades, over the past decade, and now we have further subgroups within these grades. We have 4 subgroups within SHA, and we have 8 subgroups. SHA is one in 10 falls. We have around 8 subgroups within non-range non-SHA. And these are all including the WHO 5, which is the latest edition of classification of seven. Now, there have now these consensus groups play a great role in the outcomes of the patient, which has an excellent outcome, with an overall survival of more than 95%. Even there's a range of outcomes for non-responders. In fact, these diagnoses using linear histochemistry. But since my research is non-responders, the reason is last year there was a group of minors et al. Which showed that the overall and progression-free survival difference between the subgroups contained in group 3 and group 4. Some of them having more than 95% US survival, while others having less than 30. And thus came up with a new stratification system, which included very high risk and standard risk and low risk categories. Very high risk had more than had less than 20% survival, whereas low risk had more than 9%. So this brings me to the objectives of my study, which is to come up with a minimum methylation distinction that we can use to classify them into risk categories and also in the subgroup. And to combine standard risk and high risk here because it is get comparable outcomes and it is that's the same. So I use a machine learning approach. We took a data set that is contained around 30 samples. We divided into training, testing, and validation data set with feature selection. We then applied a bunch of strategies to minimize those features as much as we could without compromising accuracy, and then we trained our machine learning model. So the first step was to classify the risk category and to select features. We obtained a balanced data set of 300 samples for this category. We did feature selection using Baruta algorithm in R. So we identified 750 DNA methylation sites for classify the risk category based on. You can see there in the right side, this is called a UMAP plot. It shows unsupervised clustering of the sample using the overall 450,000 DNA methylation sites. You don't see some good clustering here. But using our identified 715 methylation sites, we can see samples that clustered really well, showing that we can classify them. Next was now 750 is a big number. We need to minimize this. So we use the approach for differential methylation using the package in R to identify the 30 more differentially methylated CDG sites on DNA methylation. You can see the updated map here. Here we have some good clustering, and on the left side you see heat map which shows the methylation spheres which differs across the categories. You can also see the 30 CDG sites on the far left. Next was to train machine learning models to see if they can classify using 30 CDG sites. We trained a bunch of machine learning models to see which will work best, and two words really good, giving us an accuracy of 96.67%. It was arbitrary neural network and chain neural network. This is the completed matrix which shows the performance of the model. So 30, we still got 30 of the model. So we further try to reduce it by two strategies. One was to consider only those DNA methylation sites are consistent to stratification, and the other was we formulated a new algorithm which would remove those sites which result in the decreasing. This is the updated plan with those 14 CDG sites on the far left. We trained our machine learning model to see how they perform, and it gave us an accuracy of 94.07%. So these are questions that I've been mentioning is overall internal data sets, so we can't trust them because they are trained on this way. So we took a data set which was completely unseen by the algorithm. The feature selection and the training algorithm. And it's still numbers and it will be progress. So pretty good. Next was classification into subgroups. Now there are 8 subgroups, so this was quite challenging. But still we were able to identify 99 DNA methylation sites which was clustered really well, as you can see in this UMAP plot. So we use the original 14 CDG sites which classified them in risk categories, and the cluster didn't cluster really well. So we use the same strategy all over again. We identify the 22 more differential methylation sites, and then this is the heat map showing its methylation status. This was again shortlisting 14 CDG sites which were classified into 8 subgroups. Now, I want to mention that these 14 CDG sites are different than we use for this. So on our machine learning model, it gave us an accuracy of 94%. But this was not so the confidence is so much, so we took and in terms data set of transfer algorithm, it still gave us an accuracy of 93.9%. So this was the concept. way forward. Obviously, you would further want to refine our pipeline to improve water liquidity. You would want to know what genes are present. So it would be nice to have those genes like human suppression, for what reason the human suppression genes, so we can teach them using methylation or biology. Down the road, we would want to classify all CNS tumors because they are mostly classified using the methylation. And we will translate them into operating data just like this article by that's all these are my so these were all the data set I used. It is from the 29th paper of Sharma and all.
वो बड़ा है वो डेप्थ है वो क्लियर हो जाएगा जिसके ऊपर मामला करता है लगाना चाहते हैं